Hello everyone, today we'll be talking about chalk, specifically in pediatrics. So there's this variabilities in what we consider chalk in pediatrics versus adults due to the different physiologies of both populations per se. So we're going to start with talking about what is chalk. So you'll see in this lecture we'll be taking multiple references. So we'll talk from Nelson, we'll talk from Furman's Pediatric Critical Care, we'll use some Peds in Review articles, and we have borrowed these questions from the Peds in Review articles. We have referenced that at the end. We'll use multiple diagrams and everything from these references, which is going to be referenced at the very end. So first things first, this is a question that we will answer later. So what is shock per se? So this is a child with shock is admitted to the PICU. The attending physician assessing the patient during grounds informs the clinical team this patient has reached a critical point in their shock. A critical point in their shock. Which one of the following pathophysiological changes best describe? So best describe the time at which the critical point of the shock appears. So is it when the blood pressure drops below the 5th percentile? Is it when further resuscitation management is unsuccessful? Or is it when the oxygen extraction depends on oxygen delivery? Or is it when the mixed venous oxygen falls below 70, or warm shock becomes cold shock? As we progress through this presentation, we'll know more. So, what is shock? Shock is basically an acute circulatory dysfunction that leads into poor or low oxygen delivery that does not meet the high metabolic demand or the metabolic demands of the body, causing cellular or tissue hypoxia. When we look more, we need to understand general information about shock. So shock is the leading cause in pediatrics for morbidity and mortality worldwide. There is many different types of shock, which we'll talk about later on, but to enumerate them, there's hypovolemic, there's cardiogenic, there's distributive, there's obstructive, dissociative. An irreversible shock is usually a late stage of all of these. It's a mitochondrial injury per se. And then the highest mortality for the board's question is going to be septic shock. The most common cause in pediatrics is hypovolemic shock. The most common cause of hypovolemic shock in pediatrics is severe gastroenteritis, so diarrhea and vomiting and severe dehydration. In children less than 5 years of age, the leading cause of mortality related to shock is diarrheal illness, infectious disease, and motor vehicle accidents. In neonates, however, the common shock is globally due to either birth trauma, infectious disease, or congenital heart diseases. So, quick important definitions before we continue. And these definitions, I got them from Nelson, and I believe we should address them early on before we continue to talk about shock per se. So the international consensus defines pediatric sepsis, and there's multiple definitions. So first of all, what is SIRS? What is systemic inflammatory response syndrome? And per se, it said it needs to meet 2 of the 4 criteria. And it said one of those 2 criterions must be either abnormal temperature or abnormal leukocytic count. So, first thing, here it's hypothermia or hyperthermia or fever. So a patient who has a fever of 38.5, so 101.3, or less than 36 Celsius is 96.8. And that one specified said it could be rectal, it could be bladder, it could be oral, it could be through a central catheter, which means tympanic or forehead or axillary per se was not entered, because you want to measure a core temperature, and in pediatrics we knew that the most accurate measurement of a core temperature is the rectal temperature. second thing is tachycardia, and they define tachycardia by being anything more than 2 standard deviations for the age, but there's a caveat, right? So without any external stimuli, without chronic drugs, without painful stimuli, or it's just an unexpected persistent elevation over like half an hour to 4 hours, or if that kiddo is less than 1 year and is persistent bradycardia over 30 minutes. In the absence of vagal stimuli, beta blockers, or congenital heart disease. So what they're telling you is tachycardia not explained by pain, external stimuli, or pain, or drugs. Same thing. If the patient has unexplained persistent bradycardia, that could be a sign of shock, which we will discuss which shocks usually have bradycardia in them, and some shocks outside of these two, which could be cardiogenic and neurogenic, could have less than 10%, can present with just the bradycardia aspect of things. 3 is tachypnea, which is basically either 2 standard deviation above the age or acute need of mechanical ventilation that's not related to neuromuscular blockage or general anesthesia. And the last criteria is elevation or depression of WBC. And you need to understand something. 1, it has to be not secondary to chemotherapy. 2, there needs to be no more than 10% immature neutrophils in it. So, if we discussed already what is SIRS, then what is sepsis? And you will hear a lot on your floor when we say patients admitted for a sepsis rule-out. Sure, what does that mean, being admitted for a sepsis rule-out? And are we admitting any patient for sepsis rule-out, or is that clinical diagnosis? So sepsis is SIRS plus a suspected or proven infection. So you don't admit them to rule it out per se, because if they already meet the criteria from before, plus you're suspecting or have a proven blood culture or respiratory biofire or cultural biofire that already proves the infection, then that does not make sense per se. So then what is severe sepsis? And here, this is gonna kind of be almost the same, because you're going to be talking about severe sepsis and you're going to be discussing septic shock, and you'll see that their definition is almost exactly the same. So severe sepsis is basically sepsis, which is SIRS plus, let me try to see if I can change the color. So it's SIRS plus infection plus one of the following. So cardiovascular organ dysfunction, which we will discuss later on, or PARDS or ARDS. And it has its own criteria for different day, but basically it's telling you whether the PaO2 FiO2 ratio is less than 300, or there's new infiltrates on chest x-ray. I think the old definition had to be bilateral, and there's no evidence of left-sided heart failure, because we need to rule out that the ARDS is secondary to pulmonary congestion, secondary to left-sided heart failure. And then there's a discussion about MODS, which is multi-organ dysfunction. So severe sepsis is basically criteria about either cardiovascular organ dysfunction or acute ARDS in a settings of SIRS. And we'll find this is equivalent to what a septic shock is, right? Because we said a shock is a cardiovascular dysfunction of maintaining homeostasis. So here, why are we mentioning ARDS in sepsis? We know there's multiple causes of trauma that can occur to the lungs. We can initiate it through bowel trauma when the plateau pressures are above like 30 centimeter mercury or centimeter of water, or volume trauma if you're giving the patients tidal volumes, let's say equal or above 12 mL per kg. It can cause atelectotrauma if you have low PEEP But there's also something called biotrauma, and the biotrauma is a result of inflammatory response. If a patient has inflammatory response secondary to sepsis, it can cause ARDS. And the discussion of multi-organ dysfunction is basically sepsis plus two organ dysfunctions, whether renal, respiratory, neurological, hematological, or hepatic. The reason why we're mentioning this is because there's so many scores for it. And the definition of multiple organ dysfunction syndrome is basically the presence of altered organ function such that homeostasis cannot be maintained without medical intervention. And they decided to do multiple predictive mortality scoring. Let's like the pediatric logistic organ dysfunction, the PLOID, or severity scoring. And this is the PLOID, or severity scoring, which is basically the pediatric organ dysfunction information updates, which is short, can be shortened for PODIUM. And PODIUM is mainly a severity scoring. PLOID is mainly a predictive outcome scoring. I think there should be an easier way to do this. There we go. Okay. So this is a criteria basically for organ dysfunction, and you can see this is just the criteria from Nielsen. But again, the PLOID and the PODIUM have actual scores, and it's important for critical care boards per se. I don't think they're important for pediatric boards, but this is the dysfunctions. So if a cardiovascular, they're telling you, so in spite giving isotonic intravenous fluids of more than 60 ml per kg per bolus within the first hour, which is the golden hour overall. There's hypotension below a certain blood pressure. There's MAP below a certain target or a percentage. Or you need a vasoactive to maintain normal blood pressures. And they basically said either dopamine more than this dosage or dobutamine, epinephrine, norepinephrine at any dose whatsoever. Or two of things. You have an unexplained metabolic disorder with a base deficit. You have an increase to your lactate. You have oliguria. You have prolonged capillary refill. You have core to peripheral temperature gap. And all of those basically tell you a cardiovascular dysfunction, which if is present is basically septic shock. If you have another, will be a cause of multi-organ dysfunction. So either hepatic, renal, hematological, neurological, and respiratory, and all of each has their own criterion. So I keep saying homeostasis. What does it mean? There's a fancy definition that I was able to find, which says basically it's a state of dynamic equilibrium in which the internal environment of a living entity is maintained in a relatively narrow physiological range while resisting perturbation that are caused by variation in the external environment. What does this mean? It basically means homeostasis is whatever the body is trying to do to maintain equilibrium between whatever the internal environment of a cell when it fights the forces of an external environment. So homeostasis is just maintaining the balance between whatever is needed to keep the cellular function, whatever changes on the outside. That could be applied to a cell, could be applied to an organ, can be applied to a tissue, can be applied to any multi-organ, multicellular organism per se. Okay, so septic shock is severe sepsis. We already discussed this discussion. You'll see certain hospitals tell you criteria is if a patient needs more than 2 or 3 full boluses, then they need to go to the ICU, for example, because despite giving this amount, or it's either 60 mLs per kg or 40 mLs per kg, and you usually give them 10 to 20 mLs at a time, within the first hour, patient still being hypotensive, needs vasoactive drugs, or have one of those explanations, These will lead to an extent that this patient is in shock and needs a further monitoring and invasive care. So we have a question coming up. So the question is this: you're taking care of a patient. Usually when I read a question, I like to read it the other way. Which one of the following clinical patient findings is most consistent with the earliest clinical sign of shock? And so it tells me, so I can answer it without looking at the question. However, but they said early signs of shock in the clinical patient finding. You're taking care of a patient in general pediatric floor has been persistently tachycardic since admission. As you evaluate the patient, one of the concerning clinical diagnosis is this. So what's the cause of it? So it's going to be, right, tachycardia. Capillary fill time, yes. Cold extremities, yes. Decrease urine output, yes. Loss of peripheral pulsation, yes. But all of these are not the earliest sign. The earliest sign to maintain homeostasis by a patient in pediatrics, which we will explain later on, is going to be tachycardia. So let's explain it then. So more and more definitions, right? But to understand shock, you need to understand this definition and equations so that your care would make sense. So let's go from there. When we said shock is the lack of equilibrium or balance between oxygen delivery meeting the metabolic demand. That's what we said, right? So this means, how can I assess oxygen delivery? An oxygen delivery, which is going to be symbolized by DO2, is going to be cardiac output versus arterial oxygen content. So CO2 is arterial oxygen content. And what is cardiac output then? Cardiac output is going to be heart rate, which we spoke about, tachycardia, and stroke volume. And then what is arterial oxygen content? It is going to be divided into two things. It's going to be divided into what is bound and what is dissolved. And honestly, what is dissolved is really a neglected amount that is only important in certain specific situations. What we care more about is the bound and the effects by, this is a constant, and it's affected by the hemoglobin, hence why anemia per se can cause high output cardiac failure. Anemia is an important component that we need to tackle down in shock. SpO2, which is the pulse ox saturation, and arterial O2. These can be measured easily by just the CBC and SpO2. This needs an arterial stick. When we're looking at the cardiac output, we know it's a heart rate, right? But what are the components of a stroke volume? This can be easily measured, but we cannot measure this per se. But we do, because we know that the stroke volume is affected by the preload. And a preload of a patient can be measured by the end diastolic volume. It can also be assessed by what the afterload, what is affecting the stroke volume is the afterload. And basically these are all the forces that are resisting the systole of the heart. And the last component of it is contractility. So anything that affects any of those can cause it. So the preload can be affected in hypovolemic shocks. Afterload can be affected by obstructive shocks. And contractility can be affected by cardiogenic shocks, myocardium. And there's a whole thing in physiology, histology, which is called sarcomeric contractions. And it's important because when we talk about shock per se and how it affects on a cellular level, we need to understand that the real damage occur in a timely manner, which basically on the clock, because it damages these cells. Shock can develop from a failure of any of these components. We're going to talk about each of them under the shock classifications, but we need to understand in pediatric patient, cardiac output is really affected by the heart rate, not by the stroke volume. And the reason this is because the myocardial mass is incompletely developed in pediatric population. It takes some time, I think, very early on, early adolescence, when it actually starts to develop properly. So in adults, stroke volume is usually how they will compensate. In pediatrics, heart rate will take precedent. So next thing is additional important information that we need to understand is we already spoke about oxygen delivery. What about oxygen consumption? The other side of the component, which is basically oxygen delivery multiplied by the oxygen extraction ratio. And I want to tell you this. Normally, overall tissue oxygen extraction from hemoglobin is about 25%. And this is going to make sense when you talk about the next slide. And we'll spend some time talking in that next slide per se. Because basically what I'm looking at here is the oxygen demand and the oxygen delivery, or the consumption and delivery. You'll see here that at this point of the delivery on forward, it doesn't matter how much more oxygen you will provide the tissue, it will only consume what it needs. However, when you reach this critical point, this is an amazing diagram that I got from the Peds in Review article, you will see here that once you deliver less, this is independent. This is dependent on the delivery. So here's the critical point when you can't do enough. So basically, whatever you're going to deliver here, the tissue will take only what it needs. If you cannot fulfill this mark, then that's the problem. So law basically here tells you low oxygen extraction is going to happen if you have high metabolic demand decreases. So if the patient is sedated or paralyzed, there is less oxygen extraction. Oxygen utilization problem is a different story. If your patient is cyanide, so this is dissociative shock, hemoglobinopathy secondary to anemia, sepsis and shunting, so distributive shock, or high oxygen extractions but low oxygen delivery, and the mnemonic for it is like this. So it's either a problem in oxygenation, problem in hemoglobin, so anemia, problem in the heart again, heart and heart, right? So cardiogenic shocks per se. What about high demand and high extractions? And this happens in an inflammatory response, hypermetabolism such as thyrotoxicosis, pheochromocytoma, exercise, shivering, and that's why this makes a difference. For example, when we're tackling TBI, the reason why you don't want to do cooling measure in TBI patients if they're spiking fevers is that you will induce shivering, and shivering will increase the demand, which you, one, are trying to decrease, and two, because shivering will increase the ICP. Anyway, so no, and increase worker breathing. So understanding this is that whatever happens once you hit this point is a time-dependent cascade, because all of what's going to happen is that the cell is going to switch from oxidative metabolism to an inefficient anaerobic glycolysis. And if someone remember biochemistry, which I certainly do not most of the time, but you remember that anaerobic glycolysis will produce like 2 ATPs instead of the 38 ATP, which means there is cellular energy deficit. And I'm saying time-dependent cascade because once that cell starts increasing in hydrogen ions, increasing in lactate, increase intracellular sodium, which causes cellular swelling and rupture and apoptosis. We're talking about cellular death. And the thing that we don't know, that there's an increased risk of reperfusion injury the longer we wait to resuscitate these patients. That's why everything will be discussed in like the first hour of presentation. And remember, there's so radical oxygen and nitrates that when they are produced on the cellular level, not just cause cellular damage, but they can cause damage to the DNA and they alter the actual gene expression. And the problem is, once this cascade starts, it's only a matter of time before multi-organ dysfunction occur. So, look, remember this. If we're talking about a deficiency in the oxygen arterial content, it can cause local tissue ischemia, it can cause infarction, or it can happen with solid organ transplant, but it can still be global. If we're talking about cardiac output, then it's global tissue ischemia. If we're talking about oxygen demand, then it can be, for example, septic shock when the supply is still the same by the heart, but the demand increases. So remember, what is shock? Shock is an acute circulatory dysfunction to meet homeostasis. I hope that makes sense. This is the next question, right? So, question is, which one of the following types of shock is presenting in this patient? This is a 17-year-old that comes to the PICU, had initial resuscitation for multi-organ trauma from a motor vehicle accident. Patient had a Glasgow Coma scale of 5. Patient was intubated. Patient was already resuscitated with a crystalloid fluids. Already you see the packed RBC, awaiting bedside sign-out by the surgical team. And the patient arrives to the ICU from the CT scan. Blood pressures low for the patient's age. Heart rate is low for the patient age, even though you would assume the patient should have compensated or reflex tachycardia. Oxygen saturation is 93, an FiO2 of 40 or 0.4, and patient has good temperature, so afebrile. Which one of those? So the key hallmark is this is a trauma patient whose heart rate is 60. You would deduce from this that the patient can be having a neurogenic shock, which is a type of distributive shock. Okay, so types of shock per se. Well, let's think of this. Hypovolemic shock, which basically means volume loss. It can present with tachycardia, cool extremities, and decreased urine output. Physiological changes. There's a decrease in the cardiac output. There's a decrease in the preload, which makes sense because there's a decrease in this. There will be an increase in systemic vascular resistance to help with tissue perfusion, and there's a decrease in central venous pressure. These are the examples for it. This is what you usually need to do. And when you do a POCUS, point of care ultrasound and IVC, you're assessing two things: collapsibility and fluid responsiveness. And here you do targeted IVF, intravenous fluids, and balanced blood products. And notice targeted. You can always refer to the other lecture when we're talking about de-resuscitation, and understand that when you're giving fluids to a patient, you're giving him a medication. You're giving him also something that can have side effects. So it's not a benign intervention. When we move on, so that's why it's targeted. So you need to always realize how many boluses are you giving, and you need to always reassess the patient, and we'll talk about it later on. Cardiogenic, which is a cardiac defect, will present as tachycardia, if possible, cool extremities, decreased urine output, crackles, and pulmonary edema when it's left-sided heart failure affection. There's decreased cardiac output due to myocardial depression or decreased myocardial contraction, increased systemic vascular resistance, and increased central venous pressure because of the back pressure that is going to occur in the right ventricle. And the right ventricle and the whatever venous system you're measuring that central venous line from is usually jugular, or you can measure from any central line. In pediatrics, probably femoral. Heart failure, arrhythmia, myocardial infarction. These are good measurements, and you need to make sure that, we'll talk about it later on, that your electrolytes are quite controlled. Cautious intravenous resuscitation, inotropes, cornotropes, and lysotropes, and ECMO. Distributive shock, and distributive shock is dependent on what cause of it. It could be from anaphylaxis, neurogenic, iatrogenic, endocrinopathies, and sepsis. And we'll talk more about these examples later on. And remember, it's going to decrease and maintain your cardiac output. There's going to be tachycardia or bradycardia if it's neurogenic, and there's decreased systemic vascular resistance because there's going to be vasodilatation from the inflammatory response, whether loss of the parasympathetic stimuli or from anaphylaxis and inflammation and vasodilatation induced by a septic shock, basically from the inflammatory response. Infectious culture, CRP, procalcitonin, CBC, and again to the targeted vasopressors and targeted IV fluids. And here we're seeing hormone replenish because we don't want to forget about endocrinopathies. Obstructive and dissociative. Dissociative, let's talk about obstructive first. So basically tension in pneumothorax, cardiac tympana, pulmonary embolism, congenital lesions. And really, you need to also resuscitate these patients, but remember that the actual change is going to be if you tackle these with interventions. Dissociative is basically from the carbon monoxide, from the hemoglobinemia or cyanide. But one that we can't forget is propofol infusion syndrome, and you need to be aware of that if it happens in these patients, whether they're coming from anesthesia or you are choosing to sedate them with propofol and they're more liable, tissue sensitive to propofol. Okay, so next step, this is also a very good algorithm, not algorithm, I mean diagram from this article, and it was also presented in the Peds in Review. The good thing about this one is it really presents to you the causes in the circles. It tells you if it's hypovolemic, for example, what happens in the volume, what happens in the output. If it's a shock due to hypovolemia, then it's a loss in the volume. If it's a shock due to distributive, it's because it's a shift of the volume somewhere else. If it's a shock due to obstruction, it's the problem in output, whether it's extracardiac or cardiogenic when it's actually cardiac. And that's kind of a good parameters for it. Shock is a clinical diagnosis, and you need to understand that it's a clinical diagnosis can be often missed early on in pediatrics, because we said pediatric patients can compensate until they can't anymore. Clinical presentations, I can say early versus late, compensated versus uncompensated, cold versus warm. But the reality of things, early is basically a compensated reversible type, and late is an uncompensated irreversible type per se. And between cold and warm, honestly, they can alternate. Cold can become warm if you just do good fluid resuscitation and good antibiotic coverage. Warm can become cold if there's a myocardial dysfunction that can occur later on, for example, in septic shock. You can just differentiate between them at bedside. Warm, they have going to flash capillary refills. They're going to be warm, right? They're going to have bounding pulse. Cold is just the opposite, prolonged capillary refill time, cold extremities, and weak distal pulsations. There's good examples of how to examine these patients at bedside, because everything is going to be an assessment of cardiac output and realizing early on whether this patient is in shock or pending shock or not. So bounding or thready, differential between your central and your peripheral pulsations, and it's very important. Cool extremities are different between a core temperature and a peripheral temperature, neurological status, and urine output. I have to say this, urine output can be one of the big signs that are missed if you're not having a good track of your patient. So, shock is a common misconception that it's a low blood pressure. Low blood pressure is a late presentation, and if you wait for it, you're too late at times. Depends on the overall picture of the patient, but this should not be your first warning signs for shock. And this is just the general scope of knowing what's the normal parameters of blood pressures, and I think this is going to be important for the 5th percentile. If you're looking for the 50th percentile, then it's 90 milligram mercury plus H time 2. Okay, this is actually very good. Here it will tell you why blood pressure does not equal to shock. Because if the cardiac output decreases, the blood pressure is still maintained by vascular resistance until it's no longer maintained and the cardiac output is so low that your pressure starts to drop. And it's telling you that not until the patient has lost about 40% of their circulatory blood volume that you will realize that the patient is in shock. And assuming that the patient has 80 mLs per kg. So for a patient who is, let's say, 20 kilograms, who has 1.6 liters of blood, lost about 40%, 1.6, so lost about 640 mLs. How much are you giving them as a bolus? If these is the patient, you give them 400. So this is a patient that if you gave 120 ml bolus, you're gonna give them 400, and the patient will be only low blood pressure at 640. So does that make more sense? That the blood pressure will only be as a late sign once the patient has already lost enough blood. And perpetuated the vicious cycle that we spoke about early on, and we said it's a very timely problem. This is an important, I did the diagram. I think it's important to see it this way per se. When you look at things, you have a patient who came in shock and you're trying to resuscitate this patient. You want to maintain a few things. One, you want to do volume resuscitation as most probably either targeted or cautious volume resuscitation to increase oxygen delivery. So you want to establish vascular access, whether it's intraosseous, central venous line, PICC line, IV, peripheral IV for at first. Volume resuscitate and replete these patients. But you need to assess the patient's intravascular volume first and plan ahead if you can for that deresuscitation, which usually is not going to be your first thing in mind, but you need to be aware if you need to assess the patient's intravascular status before you start doing this volume resuscitations. So assess the patients before you do an intervention. And then you did the intervention, assess the patient again. So how can I decrease the patient's metabolic demand to help? So one, give the patient oxygen, intubate the patient if need be, sedate the patient, give them analgesia, give them paralysis. Always remember that sedating the patient does not take the pain away, does not mean they're paralyzed. And then reassess your patient because you don't want to fall through the track. Do an intervention, see if there's any change. The last thing I would say is repeat your physical exam, do your cardiac monitoring, do your pulse oximetry, do your arterial axis, do your blood work, check the hemodynamic response, assess your patients, do it over again. So, you have a 3-year-old. Remember, regarding fluid resuscitation, which of the following statement reflects best practice for fluid administration in this clinical scenario? You have a 3-year-old without medical history in the ED, has 3 days, vomiting, diarrhea, so probably hypovolemic, found to have evidence of hypovolemic. How can you resuscitate the patient? And here they're saying, regarding fluid resuscitation, which of the following is the best practice? Give them colloids. Remember, preferred initial is crystalloids. Fluid can be given faster through peripheral inserted central catheter than any size of peripheral intravenous. True, but if you ever inserted the PICC line, it's not that easy to just put it in the ED. Fluid is best delivered at 20 to 30 mLs, given over 15 to 30 minutes. and it's usually when I resuscitate them by 20 mLs per kg. Depends on what the patient's this is. It can be 10 mLs if they're renal or cardiac, depends on what cardiac lesion they have. Patients presents with hypovolemic shock and cannot develop fluid overload from aggressive and cannot, so this is wrong. Or the push-pull method of manual living fluids is an effective and rapidly strategy for resuscitation, and that is the answer for it. And who doesn't know the push and pull method? Again, this is from the Pearson Review article, I think from their PowerPoint. They have a good demonstration of it. I've seen it once or twice done by our nurses to overcome the IV pumps. When the IV pumps is unable to push more than a certain limit just because of technical difficulties. So what they do is they close it, they pull from the IV back, turn the stop clock, push in the fluids, push towards the patient. And it's used when hypotensive and you need fluid repletion right away, right there. It's a different thing from the big monster and the multiple transfusion protocol when they bring these huge pumps. Different story. Okay. We discussed what is cold and what is warm in clinical practice, but we need to understand that when cold shock occurs with a C, the goal is to improve the cardiac output. When a warm shock occurs, you want to maintain vascular tone because it's a vasodilatation that happens. So, if you want to attack the heart or target the heart, you need to work with beta 1 and 2 agonists, which is usually epinephrine and dopamine, but these are usually in a low dose. And when you are targeting the vaso, you want to target alpha 1, and it's usually norepinephrine. Remember, you can use milrinone, dobutamine, isoproterenol as well. You can use phenylephrine. You can actually use epinephrine and dopamine to your vasculature, but you will use a high dose of it. We'll discuss the dosage later on. So this is a nice thing I did to try to gather it around and talking about different types. So first of all, hypovolemic shock. Hypovolemic shock needs targeted resuscitation. And by targeted resuscitation, I'm saying that the volume of resuscitation should be really tailored to what the patient needs. And you need to really stop if you see that the patient has any signs of cardiac dysfunction, or the patient is becoming crackly and he's becoming overloaded and the lungs are being overloaded and he's developing pulmonary edema. So remember, excessive preload may actually paradoxically decrease your cardiac output because you can overwork your heart. Most of the time, you can resuscitate these patients with just crystalloids. You can give them normal saline, you can use ringer lactate. I don't think in the literature there has been increased mortality benefit if you give them colloids, so that's why we usually prefer to give them a balance of fluid resuscitation. If that patient is in hemorrhagic shock, giving them fluids that initially is fine, but remember they need to have a balance kind of repletion of whatever products they lost. So whether you'll give them packed RBCs, whole blood platelets, FFPs, whatever they will need to recover from the hemorrhagic shock. And then the bolus at this time is usually 20 mL per kg, and we said remember up to 60 mL per kg. Recognize your criteria for shock and multi-organ dysfunction and when that you need to start using vasoactive drugs. Second thing we'll talk about is the cardiogenic shock. And in the cardiogenic shock per se, you need to early on use inotropes and plus or minus using leuciotropes, which is milrinone, making sure you optimize your electrolytes. So make sure you target the potassium to be an average of 4, your magnesium to be an average of 2, and your ionized calcium to be like 4.5 or 5, because that is going to reflect your cardiac contractility. And when they mention it, they mention gentle fluid repletion, and they mention it to be like 10 mL per kg, and examine that patient serially to make sure you're not overloading them. It's a very multidisciplinary approach. You need to involve cardiology early on to see, hey, what intervention do we need to do? We need to do an echo. Involve your surgical teams to make sure you're not missing anything. Cardiogenic shock, especially if these are congenital heart disease patients, or this patient needs ECMO, for example, and it's going to be refractory for whatever management you're going to do, and you will basically need the surgery to be on call to come in and place the ECMO lines. Or this patient, remember, with cardiogenic shock can occur in pediatrics, mainly not due to ischemia. It's mainly due to, not coronary artery disease. It's mainly due to congenital heart disease, myocarditis, thyrotoxicosis, pheochromocytoma. Septic shock actually can cause cardiogenic shock later on, and it causes myocardial depression. Okay. So this distributive shock, which can be neuroanaphylaxis, and I separated it from septic shock. The big problem and your target is your vascular tone, fluid repletion, and vasoactive medications, and really it's etiology dependent. If it's anaphylaxis, give them epinephrine. If it's neurogenic and you have the bradycardia, make sure you give them norepinephrine. If it's something like maldistributive, which is another type of distributive shock, it's really caused by drugs, so barbiturates, phenothiazides, antihypertensive. Don't forget your endocrinopathies, your toxic shock syndrome. And the second thing is septic shock, right? Golden hour, get your cultures, get your antibiotic, fluid resuscitate the patient, have your targeted resuscitation, and what about giving steroids? So it's a questionable giving hydrocortisone. There's a big SHIP study that is occurring on. It's multicentric, been halted a bit by COVID, but now they're extending to different areas globally, I think involving Canada, places in Europe, mainly France, as far as I believe, Brazil, and certain areas in the Middle East. And then there is another trial out there that they referred to in the Peds review, which is about the FEAST trial. It's mainly in the low resource settings that doesn't have ICU capability. And they basically were telling you give the patient maintenance fluids and don't give them boluses unless they're hypotensive, of course. We'll do a lecture about resuscitation and IV fluid choices and all of that, but there's big schools, 2 different schools, and their discussion was mainly about, hey, do we bolus the patients to be euvolemic and then just do 1 maintenance, or do we bolus the patients once or twice and do multiples of the maintenance? And just different styles. I think bolusing the patients to euvolemia, if you're targeted, and just doing them at 1 maintenance fluids and monitoring your urine output would be my way of choice. But you'll see people put the patient on 1.5 2 times maintenance, and it's just different criteria, different indications per se. Obstructive shock, which can be from tension, pneumothorax, cardiac tamponade, and pulmonary embolism, which all of them basically you still have to do the fluid resuscitation and all the other interventions until the actual surgical interventions comes in. But I want you to remember something. Congenital heart disease like critical aortic stenosis can still cause it through, for example, left ventricular outflow obstruction, right? So obstructive shock is not only restricted by these 3 diseases per se. Next thing, so I won't go into them, but these are different algorithms that you can always check, which basically is telling you good indications of how to follow up and what to do in the first initial encounter with the patients. This is the same thing. This is from Nelson, and it's telling you the same story of what you should do in a newborn, what you should do in an infant. And it's really good that you should be working through it step by step and discovering, hey, when do I escalate or de-escalate? Remember, these algorithms are really a guideline that just involve your clinical judgment. This is a good algorithm from the article in Pediatric Review, which is a very, very great article, which I'm gonna leave the reference down if you have access to it. And this part is basically telling you, hey, this is how to kind of think through your differentials to reach how to manage a patient with shock as well. Okay, so question is this: which one of the following is the best first choice of vasoactive medication in this patient? You have a 14-year-old. She has bounding pulses. She has flash capillary refill. She's tachycardic. She has low blood pressure-ish. The blood pressure is normal-ish. She already got a bolus of a liter. She has CVC measured at 3. Her serum lactate was 21. Ultrasound shows hyperdynamic biventricular function. The PICU after boluses. What should you do? Look at this. Actually, this blood pressure is low. So what kind of shock is she having? She is having a warm shock. So it's not the heart that is the problem, it's the vascular tone. And we said that norepi would be the best choice to address vascular tone. This is a good really explanation of all the drugs that you can use, the vasoactive medications, and when to use it. The only thing I noticed is these numbers need to switch because the low dose is higher than the high dose. So the only thing is recognize the difference between them, and remember when to use what. We use the low dose in the cardiogenic, we use the high dose in the septic shock, and there's no true max when you're using it. But you have to remember, if you have a patient that is reaching like 0.2, 0.3 in the adult trials, when they were talking about hydrocortisone, they were like on 0.4, 0.5 of epi. But always recognize it's based on your clinical judgment if you're going to use hydrocortisone, and if that patient, for example, is having any endocrinopathies or endophenotype, and that this patient per se has adrenal insufficiency, or this is an asthmatic patient, or this is a patient that usually gets steroids, let's say rheumatological patients, then giving them early steroids might actually help recovering their shock. Again, it's very questionable, the use of steroids, and based on your institution and based on your clinical judgment. So the last question that we started with, what is shock? So which one of the following pathophysiological changes best describe what is shock? And basically shock is the oxygen extraction depends on oxygen delivery, and that's when the patient reaches their end point. These are your references from Nelson, from Furman and Zimmerman, from Roger, and this is the very good Peds Interview article on pediatric shock, which I highly recommend to read, and I'm thankful that I took so much of their resources here. Thank you, and if I said something wrong or there's any misconnections or something that I need to further explain, please let me know and I will adjust in future. I left the references in here. If you need anything, please reach out and do read them more, and things always change. Remember your institution protocols, and remember your clinical judgment, and remember that shock does not equal to low blood pressure, and you need to always reassess your patients to determine it.